will discuss about the most important things and most common killer in the world, that's what we call it a pulmonary neoplasm. Bronchogenic carcinoma is the most common malignant in the man and second most common carcinoma after CA breast in the woman. A number of neoplasms affect the airway, and suspicion of the carcinoma of bronchus should be promote thorough to diagnosis to make of this diagnosis at an early and therefore a treatable stage. Any tumor, any part of the body should be well discovered and early. It will have a good result either by surgical treatment or by combination of deep X-ray therapy or cytotoxic therapy beside the surgical procedure. So the most important in any suspicion of the tumor, you should be discover it and diagnosis early to proceed of your treatment. Each year in the USA, there are more than 450,000 excess recorded cases of the bronchogenic carcinoma. About 30,000 in the UK. It is 9 to 10 times more likely to die before the age of 70 among the smoker and than non-smoker. The smoker, it is increased the risk of the malignancy more than 10 times more than the non-smoker. Non-smoker is not immune to develop of the bronchogenic carcinoma, so it will be affected. This is sometimes it is an environmental causes that to lead. So 70% of the population must not be too subjected of that unnecessary health hazard. This is what we call it a passive smoking, not an active smoking. And when you smoke a five cigarette, the passive one, he took a one cigarette, which is a more risky for this one. So all over the world, they prevented to smoke in the closed area. The histological change in the bronchial mucosa occurred gradually over many years. Those who stop smoking will sharply reduce the risk of the development of bronchogenic carcinoma in the future. This is the view that we see during the surgery when we open out thoracotomy or sternotomy for cardiac one. We see this the lung, a healthy one. It will be a pink in color. Otherwise, when a smoked one, it is full of this smoked black spot all over the lungs. So always it's preferable to not smoked. Now, tumors of the lung, as in general, we have a benign and malignant one. A benign, either we have what we call epithelial tumors, fibroma, hamartoma, or bronchial adenoma. Malignant one have either a primary or secondary metastasis. The primary one, it is have a sarcoma. It is a very, very, very rare occur in the lung, sarcoma, but the more common have what we call it a carcinoma. And this carcinoma also we can classify it in two parts. Either what we call the most important non-small cell lung cancer, and this is divided to the 8, and we have also what we call it a small cell lung cancer, what also we call it an 8 cell carcinoma. In non-small cell lung cancer, the most common we have a squamous cell, what we call it epidermoid carcinoma, or maybe you have adenocarcinoma, and this is adenocarcinoma, maybe a senior in type, a papillary in type, or bronchoalveolar, which is the most serious one. It is rapid distribution all over the body, especially in the brain. Even the small size of that tumor, it have capability to metastasis outside of the lung, especially in the brain. And also we have what we call the solid tumor with the mucin. Large cell carcinoma, what we call the giant cell, or we have also a clear cell carcinoma, or maybe have a combination of both squamous and adenocarcinoma. That's what we call it, adenosquamous carcinoma. These are the most killer in the male in the world, and in the second in the female after CA breast. Secondary metastasis to the lung. Lung, it is like the liver. The first station of metastasis, any part of the tumor may be have either in the lung or in the liver. From thyroid gland, metastasis to the lung, or from the breast, or from the lymphoma, leukemia, or in the thoracic organs like in the esophagus, or even below it in the stomach or large bowel, even in ovary, in uterus, or body tumor, or melanoma, or kidney tumor. Now, the incidence is more common in the male than female because it's a more smoker. Now, because the female it is now smoked more than the male, maybe in the future we have the increased incidence of bronchogenic carcinoma in the female beside the male. The most important etiology of that one, it is a smoking or atmospheric pollution, especially in asbestosis that have well in worked in the factory that have a pollution of asbestosis. Also the urbanization because of the increase in industry in the area of the technology and air pollution, it will be affected of the environment and more lead to high risk of getting bronchogenic carcinoma, especially when we work in the factory that with chemical material, radioactive one, it lead to the more incidence and increase of the risk of the bronchogenic carcinoma. Now, with the pathology of that one, we have two things you should be remember it in general. And any tumor in the body, we have a macroscopical appearance and we have a microscopical appearance. In macroscopical appearance, always we have a bronchogenic carcinoma. More common site, it is in the right lung, more than the left lung. It is more than 6 to 4 1. We have in the upper lobe than the lower lobe. Yeah, it is more common in the right lung than the left lung. It's more common in the upper lobe than the lower lobe. Either it will be centrally or peripherally. Centrally, it is more common by squamous cell carcinoma due to the smoking, though this is an ear representation of this tumor. Adenocarcinoma, it is always in the peripheral, so it is not detected early like the bronchogenic carcinoma of the squamous. So the peripheral may be discovered either due to the lung abscess, due to the necrotizing tumor, so it will be discovered later, not like the central one, which is an early presentation of signs and symptoms. Microscopical appearance, squamous cell carcinoma presented more than 60% of that one. And cell, it is only 10%. And anaplastic or undifferentiated and large cell, it is 20%. And adenocarcinoma, it is the main other things. Now, how to can present it for you, the bronchogenic carcinoma? It is depend on the site of the lesion. Either it is a centrally or peripherally. And if it is invasion of the neighborhood structure like the phrenic nerve, or maybe affected of the lung, of the diaphragm, or maybe affected of the esophagus. So any part nearby in the thoracic part may be affected. So it will be have a sign of symptoms of that organ. It will be affected by the tumor. or maybe it is an extent of the metastasis, يعني mean either intrathoracic cavity or outside the thoracic cavity. Now, the presentation of that one, as I mentioned, squamous cell carcinoma, it is always a centrally, it is a representation, but the adenocarcinoma, it is in peripherally. So when it is a small one, they have no sign and symptoms, and this is discovered accidentally by doing a routine chest X-ray, you find a mass. Or maybe you have asymptomatic bronchopulmonary symptoms, mean a cough, hemoptysis, or recurrent respiratory tract infection or pneumonia. Also, maybe have a sign and symptoms still in extrapulmonary, but still intrathoracic symptoms, like involvement of the pleura, lead to the malignant pleural effusion, or maybe involvement of the phrenic nerve lead to the paralysis of the diaphragm and lead to the paradoxical movement. When you have a paradoxical movement of this diaphragm lead to the what we call it mismatchment between ventilation and perfusion, lead to the dyspnea and even sometimes have a central cyanosis due to the mismatch between ventilation perfusion due to the paradoxical movement of the diaphragm due to the phrenic nerve involvement or paralysis. As I mentioned, it is more common in the right lung, in the upper lobe, more common than the lower lobe. So maybe have an obstruction to superior vena cava, superior vena cava obstruction. It will be presented with a congested increase of the neck vein, and we have an increase of vascularity, venous vascularity in upper part of the body. Maybe affected of the esophagus, lead to the dysphagia, and maybe affected a brachial plexus. The brachial plexus, when affected, this is what we call the tumor, a Pancreas tumor. Pancreas tumor, or another name we call it superior sulcus tumor. Either I give you in the exam what is a superior sulcus tumor or Pancreas tumor. You should be know this is a tumor affected of the upper lobe, and it will be invasion to the brachial plexus, and early presentation, it is upper limb paresthesia and pain. And it should be always when you have a pain and paresthesia of upper limb, not only to consider this is a rheumatological cause or orthopedic cause due to the osteoarthritis, or we have any disc problem, it lead to this. But you should put it in your mind, maybe there's a tumor of the upper part of the lung, and a division of the brachial plexus, and this is always we have an erosion of the first and second rib of the affected side, either left one or right one. This is what we call the Pancreas tumor or superior sulcus tumor. The presentation, it will be neurological more than bronchopulmonary symptoms. Maybe the tumor it is presented an extrathoracic metastasis symptoms. The tumor, as I mentioned, especially in the bronchoalveolar one, clear cell or RAS cell one, it is have ability for rapid metastasis to the outside, especially to the brain. For always when you have a suspicion of the bronchogenic carcinoma and discover, you should be do a CT scan or MRI of the brain to exclude any secondary metastasis to the one. Also, you have a pathological fracture, maybe you have a metastasis to the bone, and this is especially to the hip bone or to the vertebra. This is it will be affected of the bone. So we have accidentally have what we call it pathological fracture. When you have a pathological fracture, you should be looking for the underlying carcinoma, hidden carcinoma. And the liver metastasis, it will be discovered. Then immediately this patient may be developed a jaundice in the future due to the metastasis of the tumor from bronchogenic to the liver. These are the most important, but sometimes we have what we call it extra thoracic but non-metastasis symptoms. We have no mass, we can find it in this area. This is due to the secretion of some hormones substance by the tumor, like in Cushing syndrome, due to secreted of ACTH, or carcinoid syndrome, carcinoid tumor. This is a bronchospasm and diarrhea and flushing of this patient, or due to the antidiuretic hormone syndromes we have, or we have hypercalcemia, or maybe have hypoglycemia, and also maybe have gynecomastia. These are the tumors, secreted hormone-like. This is the lung cancer that we see it. They're affected by the air pollution, radiation material, or we have a chemical, or the most common one, the air pollution by industry, and the most common killer, it is the smoking. You can find it, the tumors, it will be affected either peripherally or centrally. Always is better to cease smoking. This is for your future and for your sibling. Now, this is the diagram to show the metastasis of the lung or bronchogenic carcinoma to the liver, to the bone, and to the brain. Now, how you can diagnosis of the bronchogenic carcinoma? Bronchogenic carcinoma routinely by 2U of chest X-ray, BA and lateral, CT scan of the chest, sputum send it for cytology, bronchoscopy. This is either fiber optic bronchoscopy you can do through it. Then we can take a brush or wash or biopsy. Sometimes we do a needle biopsy under screening by the ultrasound or CT scan to take a biopsy. This is especially when you have a peripheral part of the tumor. We can't reach it by the bronchoscopy. Or even we can, by staging, we do a mediastinoscopy, or we can do a mediastinostomy. It is either by a scope or a stomy by opening of the mediastinotomy. And sometimes we can do by thoracoscopy, or sometimes you should have to confirm your diagnosis by do an open lung biopsy. Barium swallow and lung lymph node biopsy. This is important to exclude any invasion of the esophagus. A lymph node biopsy, it is more we have metastasis, what we call it scalinous lymph node. This is when we have, especially we took a biopsy from the supraclavicular region of the right side. Even the tumor in the left side, we took a biopsy of the lymph node in the scalene lymph node in the supraclavicular region. This is to confirm this is a metastasis lymph node or not. After that, when we reach a diagnosis, now we start the treatment. But unfortunately, because of two things, either it is delay in diagnosis, or maybe the patient, when we discover an early tumor, he refused the surgery, but later on, after several years, because of the severe complaining of the sun and symptoms, he consult you again but this is unfortunately at that side it will be inoperable. Two things we have in the surgery: either we see this is operable or inoperable, and two term we do, that's what we call it's a resectable tumor or unresectable tumor. Operable or unoperable, this is before a surgery we do it, يعني pre-op the diagnosis. This is either I do a surgery for that one or I can't do a surgery for that one. When I do a surgery for that one, when I an open thoracotomy, I say this is it will be resectable. I can resect the tumor, or I say unresectable because when I open that I find it the tumor it will be invasion the vital organ like the atrium, left and right atrium or left atrium, or maybe invasion to the aorta or invasion to the esophagus. This is what we call it unresectable, unresectable, unresectable. So only 10% of this unfortunately have a curable a tumor resection on the presentation. This is depend on the generally on the TNM, يعني T size of the tumor and the lymph node and metastasis, يعني this is metastasis. We classified of this tumor according to the stage. We have a stage 1, either stage 1 have A and B, and we have also stage B, stage 2 have an A and B, and we have also stage 3 A and B, and we have a stage 4. The stage 1 A and B, we can't do a surgery. Stage 2 A and B, we can do a surgery. Stage 3A, we can't do a surgery, but the stage 3B and the stage 4, it is, يعني we can't do a surgery for them. This is what we call it inoperable. Inoperable. So what is the grading of that one? Grading is either well differentiated or moderate differentiated or poor differentiated, and metastasis either to the peribronchial, العنوان peribronchial lymph node, or we have mediastinal lymph node, or maybe have an outside of the paratracheal, or outside of the chest, what we have in the scalene. So have many types of the lymph node. The metastasis, either it is metastasis to the liver or to the bone or to the brain. The treatment when we have two-thirds of this one, two-thirds of patients when discovered radiologically and clinically, two-thirds of these patients it have non-operable. But one-third of that bronchogenic carcinoma, it is an operable. When I do a surgery for that one, when I do a surgery for that one, when I open one and have one-third of this, it will be unresectable, and two-thirds of them I can do a resectable for them. When I open of that one, in one-third, it is an operable one. I mentioned it is only two-thirds, 60%, it is a curative resectable one. And el 41, 20% I do a palliative surgery. What this is what we call it debulking. يعني I remove as much as I can the size of the tumor. This is what we call debulking. يعني يشيل أكثر حجم من الماس الموجودة to relieve the symptoms. 20% it is unresectable, بعد ما تقدر حتى لو تريد تشوف it will be يعني adhesion and metastasis, it will be heroic surgery preventable not to do and to don't touch, either way it will be kill the patient on the table of your theater. The operation, it is either we do pneumectomy or lobotomy or bilobectomy, either by thoracoscopic or by open thoracotomy. Now, which one can I do for them a surgery. It depends on the age of this patient. Is very important. The age of this patient. The age of this patient. The most important. When you have a tumor, it is, as a patient, it is affected in 40 to 60 years of age. When we have a 70 years below, we can do a surgery for them. Either we do a lobotomy, pneumonectomy for them. But when the age it is above 70, like 18, yeah, this is understanding this patient to do for him a pneumonectomy. So the age is very important. It will be have high risk of operation. In these cases, the most important, the age, to decide the surgery for them beside the staging of the tumor. Beside the staging of the tumor, the age is very important. Either it is a young age, I can do a surgery for them because he can stand to do for them either pneumonectomy or lobotomy or bilobectomy. But in the only procedure we can do either lobotomy or wedge resection for the tumor if it is an age above the 70 or 80. These the most important things. The second one, if this patient have a cardiovascular morbidity or not. If this patient have a risk of high comorbidity of cardiovascular, have ischemic heart disease, or cardiomyopathy, it is also a limitation to do a surgery for them. Even this one, it will have a resectable tumor because of the risk of the general anesthesia and risk of the operation. As it will be a precaution to do a surgery for them if have a severe cardiovascular comorbidity with this tumor. Also, we depend on the pulmonary function test. If this patient الفورس expiratory volume it should be above 70%. Otherwise I can't do for them because he can't stand on one lung survived. And when I do a surgery for them, pneumonectomy, it will be dependent on the one lung, and this is when we have FEV1. It is reduction more than below 60. It will be heroic for this patient. It will be lead to the pulmonary crippled. So I always I prefer don't to do a surgery for them. I choose the another line of the treatment. That's what we call it a radiotherapy or chemotherapy. In case of this is a non-small lung carcinoma. In the case of the small lung carcinoma or cell carcinoma, always in this we do radiotherapy or chemotherapy. Unless we have an ostial carcinoma, it's very small, we can do a surgery for them. This is very important. A small one of ostial, maybe you can do a surgery for them. We can do a surgery. Otherwise, the ostial carcinoma is better to do treated by the radiotherapy or chemotherapy. Now, another patient, maybe he refused a surgery. He said, I can't to take my lung. I prefer to get a radiotherapy. Or this patient, he is unfit for surgery because of the comorbidity, severe diabetic uncontrolled, or renal impairment, or cardiovascular problem. So it can't do a surgery for them. Or maybe this patient, he can be beyond the surgery and operable. So I send this patient a radiotherapy. Radiotherapy is more sensitive for squamous cell carcinoma than adenocarcinoma. Chemotherapy is more sensitive for the adenocarcinoma than the squamous cell carcinoma. But chemotherapy should be used in metastasis carcinoma when the tumor is outside of the lung. So we give either nitrogen master or cyclophosphamide or vincristine or adrenomycin. In case of the malignant pleural effusion, it will be to do thoracentesis, or sometimes we can do thoracani, tube thoracostomy, and to prevent a repetition of that one, we can do either a chemical one, then injection inside the pleura to prevent any recurrence of the collection of malignant pleural effusion. Previously, when we have involvement of the pleura, as I mentioned before, we have a malignant pleural effusion, it is unresectable or inoperable. Now the a new guideline, they said even we have a malignant pleural effusion, and it can be resectable. We can do an operation for that one. Now it's a start to do an in the list of operable one, not an inoperable one, as mentioned before. Complication of lung resection, most important, bleeding and respiratory infection, or maybe, and this is a heroic one, when you have a persistent air leak or bronchopleural fistula. This is a very serious complication. This is due to the either technical problem by the surgeon. It's not good to suture the stump of the bronchus, or maybe this need to the hypoxemia. 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 Thank you very much. And I still insist you should be quit the smoking. And I hope that it will be the last cigarette today. Thank you very much. I'm sorry for disturbing you. Thank you very much. I hope that you enjoy with this lecture. Thank you.